Good afternoon, everybody. Okie doke. So here we are. We have made it through to the end of another academic year. And this will be the final Engel Rounds presentation for the year and actually the final Grand Rounds presentation of the year. So the next one after today will be Ben Lee's State of the Department in September. Yes, thank you, Tzipora. But of course, it's not really the end because we have a brown bag seminar series over the summer, as we do every summer. So anyway, for the presentation today, if you're here in the audience and have questions at the end, which we hope you do, or comments, please use the microphones at the sides and the aisles. If you're watching this over Zoom, put your questions in the Q&A box and don't use the chat box for questions. And now I'd like to introduce today's speaker, Dan Maeng, who is an associate professor in the Department of Psychiatry and one of the members of our quantitative methods core in the department, who Dan leads the efforts related to data extraction from hospital databases as part of the Q core. And his talk today will be use of a clinical measure of depression severity to assess treatment impact on total cost of care and all-cause healthcare utilization. So essentially, it's a talk on the benefits of a health economics approach, which is a very valuable approach. We don't hear about that often. And related to that, I wanted to mention that starting next year, so starting the year starting in September, we'll be having an annual lecture from the Q Core on some aspect of research methodology or how to do a certain kind of work that maybe people haven't heard about that much. And so in a way, this is the first of these Q Core rounds that we'll be having as part of the Engel Round series. Okay, so with having said that, I'd like to now bring on Dr. Maeng for his presentation.
All right. I'll see you at the end. All right. So thanks. So I've been here since 2018, and I've done a couple of Grand Rounds talks previously, but this is the first time I'm actually talking about the kind of work that I actually do. So I'm glad that I have this opportunity, and thank you, Steve, for giving this opportunity to talk about what I do. And you might have seen me sitting next to Ben's office, and this weird dude sitting there. But I have a job, I have a research interest that I'm trying to fulfill. So I'm just a chance to tell you what I do, and hopefully that gets you kind of interested in terms of things that maybe you haven't thought of before in terms of what you're interested in looking at. So I'm a health economist by training, health service researcher, health policy, and what it really boils down to, and this is something that I have trouble with, trying to describe my job to my in-laws and my mom and dad, and it can't really do it within just 10 seconds. It's tough. So I just say I used to work for health insurance companies a lot. So I just say, I just work for the insurance company. And they say, oh, okay. it's not true quite, right? So it really comes down to kind of thinking about, the whole discussion about healthcare cost, right? So it costs a lot. In US, we spend a lot of money, right? And then the whole question is, well, is it too much? And we say it's too much. Then the question is, well, how much is the right amount of money to be spending on healthcare? So we say, especially in the budget seasons, right? So we're talking about how much should our society as US government should allocate towards healthcare spending. And we say, well, it's too much. And they say, well, how are we going to save money? And the first approach is usually, well, let's just cut the rates, right? So this is important. So especially for those of you who are trainees, they're just learning the clinical aspects of your work. I think it's important to kind of think about where your paycheck will be coming from, right? So it's important to understand. So to start really broadly. So what is health economics? It's really, some people think it's I do accounting. Some people think I just calculate costs and stuff, but it's a bit more than that. It's broadly speaking, it's a study of how to allocate scarce resources. So we know that we have, in this world that we live in, we are subject to resource constraints, right? So then the question is, how do we allocate our scarce resources in such a way that it produces the biggest bang for the buck? That's what I'm interested in. And the question is, how does this idea of allocating scarce resources fit in terms of how we think about delivering behavioral health care, right? So what value proposition are we posing to the society and to the government and to the key stakeholders in general? And of course, we have a really unique healthcare delivery and payment system. So I did a really quick Google search of an image or a diagram that does a quick explanation of how U.S. healthcare payment system works and financing works. And this is the easiest I could come up with. so in an ideal, in a market economy, you have the consumer, in which case would be the patients or private households, and you have the healthcare providers, and there will be just single arrow going from private households, paying for their healthcare and paying for their, and the money going towards the healthcare providers. It's not so here, definitely in the United States. And actually, generally speaking, you go to any other advanced countries, that's not how it works. We invariably have some form of third-party payer system. And so if you, instead of going from left to right, let's go from right to left since we are providers. So where does our money, the paycheck come from? Well, it comes from the state government, i.e. Medicaid, right? So the whole talk about Medicaid funding issues and budget, it's always like that. Don't be surprised. Every budget season, there's always discussion about Medicaid and Medicare. And also comes to, and federal government also plays a huge role in terms of the Medicare, right? So this is the aged and disabled population. And then we also have the huge private health insurers. And particularly after the Obamacare, or what's called the Affordable Care Act of 2010, there's a whole new financial incentive that made things more interesting for me, which is, so we all carry the Excellus card, right? For most of us, right? That's issued by by University of Rochester employee benefit. So we might think that Excellus is our health insurance company. Okay, it's a payer, but it's not. Actually, our insurer is actually the payer is University of Rochester, right? So it's called a self-paid or self-funded model, where the Excellus only plays the role of claim administration, right? So they establish the guidelines for how much to pay and things like that, but the actual money that gets transferred to providers is coming out of University of Rochester pocket. So yeah, so it's a whole different system that really makes things really interesting for me, maybe not for you, for me as an economist. So this is going to be relevant, and as we think about who's the audience, right? So when we do a good job, when we say our services bring value, right? Who are we trying to convince, right? And how do we translate our performance, our service, in ways that make sense to payers, right? And so could be Medicare, Medicaid, or right, in this case, University of Rochester, which is our payer. So the question, I think, most intuitive approach, I think, from as a providers, is to say, hey, we are able to achieve these clinical goals for our patients, and we ought to get paid for it, right? But then, well, how are we going to do that? Well, we got to start paying data. We got to start collecting data in a reliable and consistent way, right? So it starts with the assumption that there are meaningful, clinically meaningful measures of performance, right, or patient outcome that we can translate into some kind of reimbursement, right? So that's what I'm trying to do in this particular study. Fortunately, in the world of behavioral health, we do have clinically meaningful data and measurements and of patient severity and outcomes. And we have PHQ-9 for depression patients, GAT-7. Again, these are very standard things to us, very standard, but when you go out there, it may not be, but at least for us in our field, these are commonly accepted things. Now, this is not unique to us, right? So in diabetes, right? So A1C, right? Blood glucose. So these are the kind of clinical measures that people really go with. Heart pressure, blood pressure, right? Heart rates. These are biometric things that clinically are meaningful. But even in these fields, there's a huge questions or concerns around the validity of using these clinical measures as a measure of your performance, right? So that's the whole point, right? So it's one thing to measure patient outcome, but to say, all right, now we're going to take these changes in clinical outcomes and translate in some kind of payment scheme, right? So that's a whole pay for performance scheme that's theoretically appealing, but when you're trying to do it in practice, there's a lot of issues, right? So I'm just gonna try to do this. Suppose I'm the insurance guy, right? And I say, okay, well, I really do want to reimburse you for the good patient outcome that you achieve. Well, can we do that, right? Using the existing data? And how much should that be, right? So that's what I'm trying to do in this study. So from my work with other clinicians, I think one of the common kind of measure of success in clinical care of depression is 50% reduction in PHQ-9 score. So that's not the only measure, but it's something I'm going to start there. We can always refine things later on, but I'm going to use that as kind of my definition of what success means. So, like I said, then if I'm able to show and demonstrate 50% reduction in PHQ-9, how much is it worth to the payer, right? And if so, if it's really the case that patient improvement correlates to cost savings and return on investment to the payer, well, then how much should we be reimbursed for that, right? So these are mundane but relevant questions, right? So that's my objective. I'm trying to see, is it possible even or feasible, right? So if we're to collect clinical data and health insurance claims data, which captures the cost of care, marry them together, right? And if we're to kind of do this a data-driven way, right? Is it infeasible? And does it yield the direction or the impact that we think it should, right? Maybe it doesn't, right? Because I'll tell you more about how the data looks, but that's intuitively, that's what I'm trying to achieve. And my outcome variables in this case are I'll describe more, but it's ultimately the cost of care. So how much as a society do we pay, or how much resource do we devote to treat these patients? That's cost of care in an economic sense of the word. And when I say all costs, it means I'm gonna look at all ED visits and all inpatient admissions, regardless of what the underlying cause might be, because we know that it's going to be difficult to kind of tease out exactly what the underlying cause of an ED visit is. So I'm just going to stay agnostic and look at all causes. That's what we're trying to look at. So the hypothesis is that does the reduction in depression symptom severity translate to lower cost of care and reduced utilization rates of ED visits and inpatient admission? Straightforward. And particularly from the payer perspective, I think that's important, right? So whose perspective are we taking in order to show our economic value too? So we often think about patients, but again, in our third-party payer system, patients usually pay very little of the total cost of care, right? If you're Medicaid, you probably virtually nothing. But if when you're in commercial insurance, like the ones that you usually have, there is a copay and deductible, right? But even then, they're usually a relatively smaller portion of the total cost of care. So who are we trying to impress? In this case, I'm trying to impress University of Rochester HR folks. That's what it essentially comes down to, because they're the folks who are kind of deciding what coverage to offer and what services they want to include in their range of services. An additional question that I'll try to get to is, well, the effect of reducing PHQ-9 might not be linear. So in other words, right, reduction of PHQ score of 5 from going from mild to none versus severe to moderately severe are different, right? So it might be the same 5-point reduction, but it can have a very different impact in terms of the actual patient outcome. So how much reduction in PHQ should we expect before we can start to see an actual economic benefit from the payer perspective? So that's another question that I don't fully address this, but I would like to explore. But I show a little bit of the data that kind of try to get at that. So this was a gargantuan effort that it has not been possible since then. So Dr. Nazra and I and Ann Cornell, we had a good relationship with HR folks back then, and they trusted us enough to share the employee health claims data that include this 2-year period from 2016 to 2018. So like I said, University of Rochester is a self-insured employer, which means that it is the University of Rochester that pays for your care, right? So that's the audience that I'm speaking to. So this information, this claims data has a lot of interesting things. Not all of it are clinically meaningful, but they're meaningful as an economist. So things like enrollment status. When did you enroll? When did you disenroll, right? What's your, do you have a dependent status, right? All these things are kind of relevant from the health and insurance perspective. And it has as a basic demographic information, and it also has ICD-10 code. So again, it is possible to do some clinical research using the claims data. So I would recommend I can talk more about doing clinical research using claims data, but it's possible. And more importantly, it has allowed amount. So what is an allowed amount? Allowed amount. So I don't know if you guys all have received this bill from University of Rochester and have seen clinical care, right? And it's gonna have the dollar values. It's gonna have the word like allowed amount. When the first time I saw it, I said, what the heck is an allowed amount? It's an insurance jargon, okay? What it means is that it's the amount of money that the provider is entitled to collect, either from the payer or from the patient, based on the contract that the insurer and the provider has at that time. Okay, that's what it means. So it means you've treated a patient, right? So the Excellus tells you as a provider that you're allowed to collect $100, okay? And under the contract, $80 comes from Excellus, $20, you go out there and collect from the patient yourself via copay and things like that. That's how it works. So I made it sound kind of like very impersonal, but it is impersonal. That's how it works. So that's what allowed amount means. And as an economist, that's what we call the price. In other words, the price is what you're willing to accept in exchange for the goods and services that you render, right? So I do not consider charge amounts to be a price. So I don't know if you've seen in your records that they have a charge amounts for whatever service that you provide. I don't believe that at all because it's not real. No one, it's like the sticker out of, it's probably less true than it used to be, but like it's the sticker price on a used car, right? It's like nobody pays the sticker price, right? So I want to look at the actual amount of money that gets exchanged between the payer and the insurer. So I want the allowed amounts. And insurance companies in general are very, very protective of this information for various reasons, but they were willing to share that information with us. And then I took that claims data and I then turned around and then looked at the clinical information that we collect from e-records and looked at all the PHQ scores, PHQ-9 scores. I don't think I collected for GAT-7. I might have. I have to go back. But like I've collected all these clinically meaningful data from the e-records, and then we try to marry them together, right? So I created a single data file that has all the clinical information, all the encounter dates, right, and so on, and demographic information, as well as how much the allowed amounts were for each of those encounters. And then that allows me to do a lot of things, right? So in this case, the inclusion criteria were, I only looked at adults in this case. I only want to look at people who had at least two PHQ-9 scores on separate dates so that I can calculate changes, right, over time. I wanted to look at people who actually had depression. So PHQ score of 10 or above. Now, I could have done 15 or above. I could have picked the different starting amounts, starting points. But again, it's as I'll show you later on, it's during this period, we did not do a good job of collecting PHQ-9 scores across patients in a consistent manner. I think we are better now, but between 2016 and 2018, that was not the case. It was pretty sparse. So just limiting these patients, the samples, to these inclusion criteria drastically reduced the sample size that I had. And also, I would make sure that everyone in my data had continuous plan enrollment, because what if, there are cases where people leave, right? And then I have incomplete claims data for that period, so I can't include them, so I exclude them. So those are the things that I did. The first thing first, though, I need to establish that there's a positive correlation, right? So never mind confounding, never mind all the kind of the noises, right? I just want to first show that there is a positive correlation between PHQ score and cost of care. Okay, so this is the issue. So like I said, one limitation is that PHQ-9 scores are measured sparsely. So it's like once every 2 months, once every 3 months, and it varies over time for each patient. So we have a reverse causality problem, right? So what we're thinking is that if we improve PHQ-9 scores, that should lead to lower cost of care. But could the reverse be true as well? So if a patient incurs lower cost of care because they're healthier, whatever reason, right? Could that positively impact PHQ-9 score? Probably, right? So then think about this. So I see PHQ-9 score in July 1st, 2016, okay? I have a bunch of claims data before and after that, right? So there's no way for me to know if the PHQ-9 score was X because of what happened before or what happened after, right? That's the difficulty of working with this kind of data. So what I said was, okay, then let's forget all the intervening values, right? So I'm going to use all the costs that were incurred in between PHQ-9 scores and do a kind of scatter plot of, okay, this is the month when the PHQ-9 score was measured. This was the total cost of care for that month, and do a scatter plot. And how does it look? So that's step one. So if I can do that, then at least I know there's a positive correlation. And then second step is, okay, then I'm gonna create these three. This was, to Dr. Lee's credit, this was his suggestion. Let's create three mutually exclusive groups. Okay. So one group meaning no improvement, right? So these are the patients within the 12-month period, their PHQ-9 scored either remained unchanged or worsened. There's a partial improvement group that had PHQ-9 improvement of less than 50, so anywhere between 1% to 49%, or the clinically significant improvement, which was at least 50% improvement. Okay, so that way I can group patients into three mutually exclusive groups, and then look at their total cost of care across. Again, this is technical, so this is insurance jargon. So this PM per member per month is how they calculate. That's the insurance measurement of total cost of care and utilization. So at any given month that the patient was enrolled in health plan, well, how much did health plan cost or pay for their care, right? And how many ED visits did they make or inpatient admissions did they make? And then I can also calculate the rates of primary care visits, because actually it turns out it's a very interesting finding personally to me, is that when you improve patient PHQ-9 score or depression severity in general, it's the primary care visit rate that goes down. It's very interesting. So it's like, it tells me a lot about like how depression is treated, right? So it's like the story seems to be that that these patients who have depression, they're not coming to us. They're going to PCPs. And their depression improve, their symptom improves. The first thing is they stop going to PCP. Right? So that's an interesting pattern that I really haven't seen in the literature yet, but I'm seeing it from my own look at the data. And I'm going to look at the total cost of care as well. And then I calculate the differences in the dependent variables across the three subgroups. So this is the sample. So it's small, right? So the no improvement group, I had 53 patients. Partial improvement group, I had 79. And the clinically significant group, I had 111. So not huge. And particularly, this is actually underpowered. And when you're trying to do insurance analysis, because cost of care tends to vary so much, there's huge variance by nature of the data. So it's I would not have been surprised to find no finding because of rather small sample size, but I still did find some, which is what's compelling to me. The average age so they're very similar across the three groups. The only real significantly different characteristic was the PHQ-9 final score, which is what we expect because that's how we defined our groups. They're mostly female. So these are all University of Rochester employees. And they had some medical comorbidities, but not severely. So these are relatively healthy, mid-aged, tended to be female population. So this is kind of step one. So this is really interesting. Again, I don't want to make too much out of this, but that bar graph is the PHQ-9 score. So the x-axis is the sequence of visits. So visit 1, visit 2, visit 3, or the measurement 1, measurement 2, measurement 3 of PHQ-9 scores for that patient over time. So so this ignores the time gap. So it could have been 2 or 3 months in between these measurements, but so I'm ignoring that for now. And then I'm looking at, all right, so so over the sequence of THQ measurements and over time, how does the PHQ-9 score and total cost of care change? And I think what's hinting at is that you can see that when the PHQ-9 score starts to go down, then there's a slight delay in total cost of care, and then it subsequently follows, right? And then when it goes back up, total cost of care goes back up as well. So there seems to be a slight delay. So again, I've not done any statistically rigorous testing of this observation, but at least that's what my eye test tells me. And when I actually do calculate the correlation coefficient, it's 0.0 and it's positive, 0.0991 with p-value of 0.00. So there is a significant small and noisy, but significant positive correlation between PHQ-9 improvement and total cost of care reduction. That's what it's saying. So that's encouraging. I'm not fantasizing things here. So there is a positive correlation. And subsequently, I kind of look at what's happening. So this is a methodology that is kind of not intuitive, but what I'm trying to say here is the observed bar is what's observed in the data, right? So the average acute care visits, PCP visits as observed in the data. The expected is what would have been expected if these same patients had no improvement in PHQ-9 score at all. So if they had belonged to the reference group, which is the NI group, so that's kind of the counterfactual of what we would have expected to see if the same patients had remained in the no improvement category over time. So the delta or the difference between the gray and the black bar is the impact. So what's showing is that there's no real significance in terms of the acute care visits. Not surprised given the relatively small sample size. But in terms of the PCP visits, you start seeing some expected results that we had hypothesized to begin with. So you can see that for that CSI group, right? So you can see that the observed, which is what's observed in the data, is significantly lower than what would have been expected if the CSI group had belonged in the no improvement group, right? So that delta is indicative of the impact, right? And then this is the cost. So what this is saying is between the NI and PI, there's no real significant, well, NI is the reference group. So the PI group, the partial improvement group, there was no statistically significant difference. But when it comes to the clinically significant improvement group, there was about 36% lower cost of care. Okay. And I didn't really show you this, but there's also 43% lower all-cost specialist visits as well. Again, when I say specialist, I'm excluding all non-behavioral health specialists and look at like dermatologists, like cardiologists, right? The medical specialists. And they were also lower by significant amount. Okay, so interpret that however you will for now. And then there's also lower PCP visits as well, which is consistent with what I had seen previously in my other studies. And there's the only significant results were observed among the clinically significant group, the highest improvement group, right? So I have to admit that there are a lot of issues with this analysis, like reverse causality, all that stuff. But despite all that challenges and small sample size, I think the overall result is pretty consistent with what I had expected to see, right? In terms of, if you do a better job of reducing PHQ-9 score, does that translate into cost of care savings? And the answer is yes. Is it predictive of it? Hard to say, right? What I'm showing you is just as a correlation or the association, right? It's hard to say this is causal because of the challenges that I talked about. But again, these are very promising, at least initial indicators. And it's also important to note that only the clinically significant group was the one that had experienced this most significant impact in terms of the economic reduction, right, or economic savings. So again, it really matters how you define success. Okay, so what it means is that if you define your success as 25% reduction, well, okay, but then you're lowering the bar a little bit, but you're also diluting the savings, right, that you can achieve, right? Or if you really, raise the bar and say 75% reduction, then you're lowering the number of patients that you can say you've impacted, right? So you're talking about a much relatively smaller portion of the population that you've touched, right? So these are the pros and cons of that. Limitations. I think, again, this kind of study would really benefit from having much larger patient population, sample size. I have to tell you, I've been meaning to do this since 2018, but it's difficult. I mentioned this here because not because it's technically challenging, it's just merging two data sets together by MRNs, but it's because of the regulatory and legal concerns about merging claims data for employees, right, our coworkers, and merging their and clinical data. And there are a lot of sensitivity around it. So I can understand the sensitivity of it, but to me, this is the most kind of logical and intuitive way to create a new pay for performance paradigm. But again, this is being frustrated because of these concerns I talked about. So I would love to do future research projects where actually we do proactively assign patients and collect data proactively, right? As opposed to, prospectively, as opposed to trying to do things retrospectively, which just makes things very difficult. However, I just can't imagine NIH approving a purely economic study like this. So I'd love to latch on to some of you who are going to be studying this, doing similar studies, and make this economic aim 2 or aim 3 of your study, and kind of like piggyback on what you're trying to do clinically and kind of go along with it. That would be a much more feasible way of going about doing this kind of study. I have to be realistic. So talk to me about that if you're trying to do similar things like this. Yeah, I'm done in terms of the actual content. Thank you. And thanks for your attention.
Thank you, Dan. Want to think about. So we already have a bunch of questions on Zoom.
Oh, okay.
Leave them.
All right.
Okay, first question. Are providers actually Is it really the case that someone didn't hear me? Okay, for those of you on Zoom. Okay, where were we? Are providers actually trying to collect the apparently highly inflated rates from those without insurance?
So you don't, but the hospital administration will. Yes. Yeah, they certainly will knock on doors, and yeah, they try to do that because they have to. Otherwise, it's not sustainable financially. So you can cut a deal. I don't know if you know this. It is possible to negotiate with hospitals and large hospitals to come with a more reasonable payments, but that is true. That's why you have all these bankruptcies, right, related to healthcare costs, which is a problem.
Okay, we have a related question, but before we get to that, Kristen?
So I guess my question is from an economic perspective, did you split out insurance policies like deductible versus like copay or whatever? Because the one with the deductible would look like the hospital paid zero for them, but the patient's paying for it. So like who's...
Yeah, so yeah, that's a good question. It's like how much is the burden falling? Yeah, how much burden is falling on patients as opposed to payers? I can look at that. I have not, because remember so I don't know if you guys recall, but we have University of Rochester offers 2 different payer insurance types, right? One is high deductible health plans and the PPOs, right? So if you have a high deductible health plan, you're on the hook up to $2,000, right? So, well, yeah, we're larger, right? So yeah, so all these things like you have to take into consideration. I just didn't have the sample size to do that kind of stratification, but It could be. For sure. For sure.
Okay, another question is, why do providers set the charges at rates so much above the allowed amounts?
Oh, I love this question. So it's all about negotiations, right? So they're gonna raise, because this is how it works. So it's when you go so I'm talking as an insurance company, okay? When you go and try to negotiate a payment with a new hospital system, okay, brand new one, okay? Usually you just come up with a percent of charges. Say, hey, I'm gonna steer, I have 10,000 membership in my health plan. I'm gonna steer all my patients towards you. In exchange, you give us discount, okay? And the discount is calculated as percent of the charge amounts, whatever that you have. So from the hospital perspective, you're gonna inflate the charge amounts, right? To ensure better receipts, right? So that's what's going on. So yeah, it's just negotiation.
Okay. All right, we got some more questions. How do high deductible policies affect your calculations?
Yeah.
This could be especially interesting with respect to employees and you are as payers.
Yeah. So in this study, I did not, but I do have data to look at that now. But again, I think the biggest challenge I had was just this sparsely collected nature of PHQ-9 scores at that time. I think if I were to do this now, I think I would have much better sample size to work off of, which would allow me to actually utilize all these nuances around high deductible health plans and PPOs. But at this point in time, the sample was very small.
Okay. Now, I think related to that, another question that came in is, this person says, I'm concerned about the denominator of the sample size since PHQ-9 measurements were infrequent and not from every patient. What are the hidden variables? Is there something different about the patients who completed PHQ-9 versus those who didn't?
Yeah. That's a good question. But I don't know if any patient is asking to fill out PHQ-9 questionnaire. It's providers are like inviting, right? That's like whenever you show up, right? So it's like, I think it tells more about us than patients, right? It's like, so like, could it be that we're offering, so again, between 2016 and 2018, that we somehow self-select or adversely or favorably select patients to give PHQ-9 scores to? You tell me. but now I think it's much better because now we're pretty much standardized now, right? So that's possible though, yeah.
Okay. George?
It's not a question. I just want to make a clarifying comment specifically about behavioral health partners, which is the clinic for the UR employees. When we set up the rates for BHP, we did not follow suit on inflating the charges. So people who are, well, obviously people are coming to us with insurance, but we don't have those very high rates if someone is coming to BHP. They don't see on their charge, let's say $600 and then an allowable rate of $150. It doesn't exist there on the BHP ledger. Thanks.
Yes. Thank you, George. BHP, good program.
Okay, another question is, how would a single payer system and thus a national database affect your work?
Yeah.
Your questions and your ability to answer them?
So it varies. So just because you have a single payer system, it does not mean you're going to have good data. Because anecdotally, I met researchers from Canada who does have a single payer system. And my immediate intuition was, you guys must have great data to do research. They said, nope. So it's like, we have better like research infrastructure and data infrastructure to do research. And so it's just because you have a health insurance single payer system, there are pros and cons. And just because you have single payer doesn't mean you have good data to work off. So that would be my response to that.
Okay. Sephora?
The Question I have is actually a combined question and comment, and it's a translational one. So most of the audience for today's rounds are not health economists, we're clinicians. And so despite worrying about where our paycheck comes from and being sure we understand the self-insured versus other kinds of insurance, I'm thinking about what we all in the room contribute to this story. So one of the things that stands out to me is when we complete a screening tool with a patient as sort of a routine part of care, we're potentiating a pool of data from which someone like you could make an argument to a payer to pay for more services, for more people, to pay the clinicians more. Are there other things that clinicians can do that may have some downstream impact on the cost of care, even if it's very distal? Because a lot of those things to many of us feel burdensome. They feel burdensome to patients. And so I'm trying to think about how we would understand the value of that so that maybe we change our perspective about it.
So that's a great question. So I go back to this whole patient-centered medical home concept that was popular back in 2010-ish. The premise was we're trying to move away from just individual clinicians working harder, or particularly primary care providers just working harder. That's not a sustainable solution. So we're trying to put together a system in place around primary care providers so that they can be more effective. I think the best way to kind of make your case is in support of behavioral health service expansion is kind of take the route of what the PCMH model tried to do, which is you can't make us work any harder than we already are. What we are lacking is a system and a coherent infrastructure so that so everyone who is working here is working at the top of their license, right? Not doing all this, menial like administrative tasks. Create a structure in place so that we can be effective at the top of our skills. We need to articulate. You need to articulate that. I think to say, make the case to the policymakers, to the payers, saying this is the structure we are lacking right now in our current system, right? And these are the supports that we need, and we need to be articulate about it, and preferably have data to support it. Right? So I think that's something to think about. My impression has been I've been in this field for 6 years now. It's like, and I don't blame you. It's like you guys are very siloed, right? Like even the payment system itself is very siloed, right? So we have whole behavioral health carve-outs and all that stuff. So kind of think outside the box and say, okay, by my service, this patient treating their depression, I'm impacting their medical side as well. How are you going to show that, right? So it's like, what system do you need in place to be able to capture the impact of your service outside of your offices? Right.
Okay, another question is, given that 6 visits seems to be a critical period for improvement, do the data argue for some sort of clinical adjustment following that time?
That I need Dr. Lazarus because again, it's difficult to say because remember I ignore that time interval between those visit sequences. So I don't know if there's anything special about the 6th visit or 7th visit or 8th visit in terms of timing of the episode. So sorry, I can't provide much insight onto that, but maybe.
That's okay. You're not required to know the answer to all questions. Now, here's another one.
Yeah.
As more mental health private practitioners are choosing not to accept insurance rates, how can this impact this kind of data?
So that's a problem because unless you're doing your own data collection, your own systematic way to not just collect PHQ-9 scores, it doesn't help you if they're on paper. Right? They have to be digitized somehow, right? And you got to collate them in a way that they can be pulled and analyzed and calculated in a consistent manner. Like as a private practitioner, I see it's very difficult for me to imagine having a whole infrastructure in a single provider office to be able to do that kind of administrative work. So I think that's going to be a big minus, I think, moving forward, right? Because right now the whole healthcare system is moving towards measurement-based care, right? It's like what are you doing to kind of follow that trend, right? And as a private practitioner, I can't imagine a single provider being able to do all that. So I think that's difficult.
Okay. And I had a couple of questions for you.
Sure.
Let's say this is a two-part question.
Yeah.
So, one is just, what do you think some of the main cost effectiveness or health economics questions in the field of psychiatry are that could be looked at within what our department does?
Right.
And the second one, I guess, is a kind of a comment and a question, which is, I was at a meeting once with a bunch of researchers and people from the insurance industry. And what came out of that discussion, one of the things was they can calculate things like, how much care would be needed, let's say, to prevent, X percentage of suicide completions.
Yeah.
And they like to know these things. No one likes to talk about it, but they like to know about it. And basically, they don't want to pay for enough care to make a significant impact there. So we are kind of like recipients of this information, but we're not the decision makers when it comes to how much payment will be allowed. So let's say if we can identify the most important questions in the field of psychiatry, what can we do to try to influence how this works? Or do we just have to kind of be dependent on what someone else decides they want to pay?
So at my previous employer, I sat at their health technology assessment committee. And this is pretty typical in health insurance companies. So whenever there's a new intervention, new program, a new drug, new device, we convene and we bring in whoever is trying to support this new program, and they would do presentation. And then we ask for their scientific evidence, right? Published literature, and then collectively make decisions like that. And there's a whole, so you've heard of Cochrane Review, right? So there's like whole group of companies that try to synthesize scientific knowledge to in support of whatever. I think we have to have much more robust research, health economics research, to demonstrate empirically, not just argue, hey, our patient feel better because of our services. Empirically show that, hey, here's commonly accepted clinical measure of severity, PHQ-9, and this is how much reduction we saw because of our service, and that's how much total cost of care we save. These will carry a lot of weight to the healthcare provider, health services research, as well as stakeholders, as well as the insurance companies, who really want to reduce cost of care. That's how we pitch our service to. Like, we got to speak the same language, right? So it's like, if we say, well, because of our service, we're able to save $5 per member per month. They'll listen to that. Don't tell me, it's like, don't tell me what the quality adjusted life year is. they don't pay. It's like, there's this huge disconnect between this academic discipline of showing value versus what the stakeholders actually pay attention to. And I'm kind of trying to bring these together and say, look, you got to speak the right language, right? If you're going to make an impact, right? You can't talk about things that they don't care about. So that'll be my advice.
Okay, so we have to get them to listen to us.
And speak the right language.
Yeah.
Right. Yeah.
Okay. Well, any final questions? Okay, so thank you again, Dan. This was a great way to end the year. And thank you for that interesting presentation. And hopefully, maybe this will interest people to take this approach in some of the research they're doing, which clearly can have real world impacts. All right, thank you all for coming, and see you all next time.